introduce yourselves. If you want to come, you could speak into the 2,000 virtual people.
Oh, sure. 2,000? That's all?
No, it's not.
That's all.
Oh, one other thing too. I'm so sorry. There are some flyers out. Dr. Glazer had announced this last time. He has the flyer out for the Dental Seminar 2024 in Longboat Key, Florida. You are entitled to a discount. What's the discount again? $200 discount. And I have an email. I have Dr. Glazer's email if you would like to get that discount. So let me just put it in here. Howard comes up as HG. hglazer264@gmail. That's hglazer264@gmail.com. That's for the Smiles in the Sun Dental Seminar in sunny Florida.
Nice.
Thank you.
Very nice. Thank you very much. It's a pleasure to be here today, as sponsor of the event here. I'm Rich Conti. I'm a healthcare relationship officer for Carney Bank. Here with Greg Kunto. He's a commercial lender for Carney Bank. Just want to tell you a little bit about Carney Bank. It won't be too long. Just so you know, we're headquartered in Fairfield, New Jersey. We have 48 branches. Our footprint goes from Top Bergen County by Northfield down to Toms River. And we have 2 branches in Brooklyn and 1 in Staten Island. And we're about an $8 billion bank. I put on your table, we have a dental express loan that is something we're running right now. It's a loan that goes up to $500,000. All we require is 2 years tax returns and an application. It's for malpractice premium financing, lines of credit, equipment loans. So it's something that can be done really efficiently and quickly. Also, and we're a relationship bank. I mean, we're different than like the Bank of Americas and the TDs. We're more relationship driven. You know, our deposit products are, very easy and simple. We have a checking account's $100 minimum, no item count fee, no cash counting fees. We have the regular suite of treasury management products, so remote deposit, positive pay for fraud protection. So full service commercial bank, but we give you that relationship service that, I think dental practices can definitely use in our expertise. So we also do practice acquisitions and commercial mortgages for real estate. I just want Greg to just say a few words about that too.
Yep. Thank you again for having us today. Just to piggyback on what Rich was saying, I'm with the commercial lending group at Carney Bank. So we do handle commercial mortgages. We'll do commercial mortgage refinances. We can also do larger line of credits for dental practices for equipment purposes. If there's a practice that is consistently buying large pieces of equipment, that's something that we kind of specialize in also. To just go with what Rich was saying, we have everything is completed locally in Fairfield. Our headquarters are in Fairfield, so our decision making is all in Fairfield. So you have myself there, the credit manager, the underwriters, the president of the bank, everyone is situated. So it makes things real easy, especially for these deals that have, different situations going on. It's a very easy thing to kind of walk across the hall or walk upstairs to get a quick answer, as opposed to sending a package to, North Carolina or Charlotte and waiting back to hear weeks upon weeks. So it's a really good experience for a lot of our clients, and I just want to thank you again for having us.
Just one last thing. We're giving away 2 bottles of wine, and we only have like 4 or 5 raffle tickets in there, so it's a good chance to win. So make sure that you come over and fill out a raffle ticket, and this way you have a chance to win. And we can announce that afterward, I guess. Is that okay?
Yes,
Okay.
we will.
All right. All right. Thank
So we
you.
don't lose anybody.
Thank you.
Or actually at the end, so no one leaves.
There you go.
All right. So thank you guys. Fairfield's not a bad place. I grew up there. Oh my God. So why don't I introduce Dr. Elise? Come on up. Hopefully we can open up your PowerPoint without much difficulty here. Let's see. Let's see where it's located, somewhere here. On a drive, right? Do you see it on a drive on the side here? Let's see, maybe on the side there. Do you see it plugged in?
No.
Is it reading this thing from here?
Can I plug it directly into the computer?
Why not?
Maybe not.
Maybe over here.
Is there one on that side?
Yep.
Yeah, that's perfect. There we go.
Got it.
Sounds good.
There it is. Yeah, it's here. That's weird. It's not here. Yeah. Oh, there we go. Yeah.
Awesome. I like great.
Okay, she just went directly.
Thank you.
And then you gotta share screen with me.
Yeah.
No problem. Switch to new speaker. Yeah, sure. Share my screen. Okay, you're sharing your screen. All right, there you go. Should be all set. Go to your PowerPoint there, I think.
Hello, everyone. I'm Elise. I'm going to be giving a case presentation on one of my patients. I'm a PGY1 at Englewood GPR. So this is a patient that presented to me. She's a 49-year-old Hispanic female. She initially presented to our clinic as a walk-in patient in September. She had pain in her lower right, which started 3 months prior. And she presented to me for a complete oral evaluation a month later in October. Her chief complaint is that she wants to replace her missing top teeth. Her last dental visit before seeing me was in September. At that visit, they found a carious non-restorable number 30, which was extracted and grafted. Prior to that, her last dental visit was in the Dominican Republic 2 to 3 years ago for implant placement. When she met me, we did a complete oral evaluation. We took an FMS and a CBCT. Her aesthetic demands, she said that she would like to close her diastemas if possible. Since I last saw her, we've just completed her perio treatment, so that being a perio and SRP in the lower left and lower right molars. As for her medical history, she does have type 2 diabetes. Her most recent HbA1c was 7.0. She has hypertension, hyperlipidemia, and gastric reflux. She takes lisinopril and 3 other medications for her diabetes. No known allergies, no prior surgical history, no psychosocial history, and we didn't inquire about any medical consult for her. She's ASA class 2. Her family history, she does have history of hypertension in her family, but as for her social history, she doesn't have any history of drug, alcohol, or smoking. This is how she presented to me. The top picture is her, but she does have a guarded smile. I try to get her to laugh a little bit, so that's the picture you see on the bottom. You can see she has a higher smile line than the first picture when she's a little bit guarded. This is the rest of her dentition. So she is missing a number 30. She has an implant placed at site number 10 as well. And the other implant located here was also placed in the Dominican Republic 3 years ago as well. These are her models. As for her extraoral exam, she has a normal physical appearance, everything's symmetrical, and there's no pathology. Everything's within normal limits extraorally. As for intraorally, she has normal physiological pigmentation, no edemas or lesions. She does have a high maxillary midline frenum, which I think might be contributing a little bit to her diastema between 8 and 9. Other than that, everything else was within normal limits on her hard and soft palate, her floor of the mouth, tongue, and tongue. She doesn't have any wear facets, and her vertical dimension of occlusion is within normal limits. She's an angle class 1 occlusion. She does have a Siebert class 1 deficiency at the area of number 10 that you can appreciate here. So she's missing bone buccolingually, but it doesn't look like there's any drastic loss of vertical dimension at that ridge. We completed a comprehensive perio exam at that visit. Most of her probings were within normal limits. She does have a couple of areas of BOP, couple of areas of 4, 5s, and 6s, mostly on her molars. Her periodontal exam showed some uneven gingival margins, at least on her upper teeth, but she does have generalized stippling and otherwise healthy. Her keratinized mucosa is greater than 2 millimeters, and she does have a thin gingival biotype. As for recession, she doesn't have any major recession except at tooth number 12, where she's missing about 2 to 3 millimeters on the facial and also the mesial and distal of the tooth. So that puts her at a Chiro class 2 recession defect. As for her mucogingival defects, she does have defects at the 2 implants she has. So at number 6 and number 10, you can see clear mucogingival defects, and we'll go further into those. She has no mobility on any of her teeth and no furcation involvement. She does have separation at implant number 10. This is only upon palpation, so it could also be a food trap in that area because you can see this implant is exposed. So as for her periodontal diagnosis, I classified her as generalized gingival health on a reduced periodontium. She has some existing bone loss, but mostly she is healthy. She does have localized periodontitis, stage 2, on her molars, and I put her as a grade C because she does have diabetes and her HbA1c is greater than 7. And she does have a thin biotype that we have to take into consideration for any further treatment. These are how her radiographs an FMS we did for her, and I'll go further into each quadrant as well. When I first took these, the thing that stuck out most to me was the 2 implants. This one not being radiographed on the radiograph, which signified to me that it was a temporary crown. And number 10, which you can see in this radiograph, it's very close to number 9. And this is just a panel derived from the CBCT scan we took of her. I'm going to go into a little bit about how we're going to classify the prognosis of implants for implant recession defects, because she does have defects at both of her implants. So a study published in the Journal of Periodontology in 2017 proposed a new classification system for implant recession. And they put implants into 3 categories: favorable, questionable, and unfavorable. And I think this is a really good reference to, when you have implants come in to your practice, just to classify them to see, is any treatment we do for them going to be favorable? So any kind of graft that you put on a favorable or even a questionable one has a better prognosis versus an unfavorable one. You're not looking at a great prognosis for any further treatment for that implant. So some factors they considered were tissue thickness. If you have more than 2 millimeters of tissue thickness, if you have more than 2 millimeters of keratinized mucosa. And another major factor that we looked at is the buccal and lingual position of the implant. And they found that the most significant local contributing factor for peri-implant disease wasn't keratinized tissue. It's actually buccal malpositioning of the implant body. Then the following 2 factors that's followed by is keratinized tissue and a thin tissue biotype. So why is the buccal positioning of an implant so important? You have the buccal bony wall, that's a vascular surface, and that's going to maintain any soft tissue that you have lying over it. Also, another 2 factors to consider are the thickness of the facial bone and also the interproximal alveolar bone height as well. That's going to dictate how your peri-implant soft tissue profile is going to look. These are some great examples of cases where there were implant recession defects, and they categorized how successful any treatment on them would be based on the pre-existing factors with the implant. So on the left, they had an implant that was favorable. It didn't have any interproximal bone loss. It didn't have any soft tissue loss. The implant was completely located within the bony housing of the arch, and it had good soft tissue thickness and keratinized mucosa. So you can see this implant, it had a recession defect, but all the other factors led it to being favorable. They did a connective tissue graft, and they got a great result in the end. You can see that in picture J on the lower left. On the right, you have an implant with a questionable recession defect. So this implant can have malposition in the apical facial placement. So you can appreciate that recession on number 9 implant. But despite this, it had a questionable prognosis due to the other factors. It still had good keratinized mucosa. It overall had a good bony position, just only part of the implant was exposed on the buccal. So they were able to, with connective tissue graft, they were able to get some of that tissue back. It's not completely aesthetic because of the questionable prognosis, but that is what they expected. And an implant with an unfavorable prognosis can be classified if it has, a patient with systemic disease, uncontrolled diabetes, uncontrolled behavioral issues such as smoking or poor oral hygiene. If there's a class 4 mucal gingival recession defect, you probably won't expect much tissue growth back. And an implant with an inadequate tissue thickness less than 2 millimeters or no keratinized tissue at all, you won't expect good results with treatment. So we put them in the unfavorable category. That's not to say that the implant is hopeless, but it's in terms of the implant recession, if you can get any growth back of tissue, then that puts it in an unfavorable category. And the last hopeless cases for recession coverage would be any severely compromised implant position or advanced peri-implant disease, so peri-implantitis as well. I looked into another study where they found what were the biggest treatment errors in the aesthetic zone, which they found were in implant positioning. So we can talk about the position in 3 different ways. So one, mesiodistal position. What happens when an implant is placed too close to an adjacent tooth, like we have with my patient. You have a risk of reduced height of the tooth implant papilla because you'll have resorption of the bone in that area of the adjacent tooth. You can also talk about an error in implant positioning in the vertical distance. So the distance between the implant shoulder and the mid-facial mucosal margin. Optimally, you want 3 to 4 millimeters. If it's less than that, you have a risk of showing the abutment or the implant shoulder will become visible. But the most common implant mispositioning factor they found was facial misposition. So either positioned too far facially or inclined too far facially. And this was strongly associated with mucosal recession. In these cases, they found that successful bone augmentation of the facial bone wall will provide a good bony support for the soft tissue, just like we expect, and that coincides with the previous study. So what happens when you have an implant that's positioned not in the best spot? In case of mesiodistal malposition, it's not possible to correct a missing tooth papilla. Once the papilla is gone, in most cases, if it's due to the mesiodistal position, so not due to the shape of the crown or the contact of the crown, specifically because the implant is too close to the adjacent tooth, they are saying you cannot correct because you can damage the adjacent tooth as well. In cases of coronal malposition, if it's not too extreme, you can attempt soft tissue grafting. And in our favorable and questionable prognosis cases, this might be a great idea. In the cases with an unfavorable prognosis, you won't get a good result. And in the cases with an axial malposition, same thing. You can attempt a connective tissue graft, but you should consider the prognosis of the implant first. The main limiting factor in the success of these cases is going to be how far out of the natural dental arch that implant comes out. So if it comes really far out, you won't expect to have a good result that matches the adjacent teeth. So we can look at her in her upper right quadrant. She's missing, looks like she was congenitally missing number 4, and she does have an adjacent number 5. And the other teeth have a good prognosis here. We have some mild horizontal bone loss, but probing depths were mostly good besides at the molars. Now, number 6 is the implant that was placed 3 years ago, and you can appreciate that the gingival zenith of this temporary crown is about 4 millimeters higher than her adjacent teeth. and the implant is positioned too far buccally, you can see that gray show through of the implant components. She doesn't have any bleeding on probing on this implant. The probing depths were good. We put this prognosis as questionable. Number 7, she has a peg lateral. Number 8 and 9 have a good prognosis. Number 10 was the most recent implant done somewhere else. And this implant, you can appreciate the show through here. This implant is clearly too far buccal, more so than number 6. The implant platform is exposed through the mucosa, and it's too close to the adjacent number 9 root as well. So this prognosis is unfavorable. You can appreciate the positioning of number 7 here. You can see that this one is too far buccal, but in comparison, number 10 here is much worse off. In terms of how close it is to, how close number 10 is to number 9, I noticed less than 1 millimeter distance between the two. I'm going to move on to her other quadrants until I get to the final treatment plan. So number 11 is a pontic off of a number 12 cantilever crown. Number 12 has a PFM crown with mesial and distal recurrent decay. 13 we're saying is congenitally missing, and 14 has decay on it as well. As for her lower left, she has some existing composite restorations on her molars, one of which has recurrent decay, number 19. 20 is missing, and 21 is distally rotated, but otherwise healthy. 22 through 27 on this patient are all healthy. 28 and 29 are healthy, and 30, you can appreciate the grafted site here. 31 has a good prognosis, and 32 is missing. So overall, my worry list about this patient is her high caries risk, her history of infrequent dental visits in the past, and if she's ready to kind of establish a dental home and proceed with comprehensive treatment. Her diabetes management, it's well controlled now, but she is on 3 or 4 different diabetes medications. So compliance will be an issue for her. And lastly, her biotype. She has a thin periodontal biotype that will make any treatment we do a little bit more unpredictable. In her case, her ideal prosthetic plan that we discussed with her is to put a number 6 implant crown number 7, and put 8 and 9 in porcelain veneers to close her diastemas. Number 10, we want to extract this implant and perform GBR in the site of number 10 and 11. We're hoping with a good result of GBR and then potentially ridge splitting, we'll put new implants at site number 10 and 11. Put a new crown on number 12, do direct restorations for caries control, and do a number 30 implant in the lower right once that site is ready. Some considerations is that the patient's satisfied with the number 6 implant restoration aesthetics. So going back to that picture where number 6 is much higher than the other teeth, that doesn't bother her. What bothers her is the diastemas and the missing tooth more so. So can we do some treatment on number 6 to minimize the gray show through? Yeah, but do we have to? If the patient doesn't want to, not necessarily. The prognosis of it being questionable is in terms of the implant recession defect. It's not to say that the implant itself will fail. An alternative prosthetic plan, if the patient doesn't want to go through additional surgeries, or if the GBR is not successful, we can put her in a bridge from 7 through 12, with 10 and 11 being pontics. It's not the worst idea in her case because she still needs crowns on some of these teeth, and she wants to close the diastemas between 8 and 9 anyways. In terms of phasing this treatment that we're planning for her, the first thing is we need to get her caries under control. We'll do direct restorations. We'll remove a cantilever bridge at site number 13 and temporize that with a nice provisional. And we'll put her in an interim RPD on the upper so that she has something to wear until all the surgeries are completed. We'll then go into site number 10 and explant that implant and do GBR. Once that site is ready, we can do implant placement at sites number 10 and 11, and depending on how much buccolingual width we get back, we may need to do some ridge splitting in that area. Her final prosthesis will be with these crowns, veneers, and implant crowns. And we'll put her on about 3 to 4 month recall schedule as well. We are addressing her chief complaint in our first phase of treatment by putting her in an RPD because she wanted to replace her missing teeth. And that's it for her. Any questions?
Great job.
Yeah.
I have a couple of questions for you, if you don't mind.
Yeah,
It's a really
please.
great case presentation, by
Yeah,
the way. I thought
thank
were
you.
Incredibly thorough, and I feel like you diagnosed the patient really well. I really love, the treatment plan that you have.
Thank you.
I guess, combination question and comment. I wonder, just for my learning, you mentioned diastema a couple of times. Is what she has technically a diastema?
Technically, it's not. Between 8 and 9, it's not a diastema. That is a black triangle. She does have the diastema in the peg laterals, the peg lateral there.
So if she came into your office, how would you quote, and she said, listen, doc, I don't want to get veneers and stuff, are there any ways to close that black triangle?
Absolutely. We can offer her cosmetic bonding. I've done a couple of cases like that where it's essentially almost like a composite veneer. It's not the worst idea in her case. Between 8 and 9, I think we can get a great result because you're saying, she doesn't have a true diastema there. It's a black triangle. So I think it's a variety of factors. I think you can appreciate that these teeth are a little bit super erupted. They're a little bit longer and they're a little bit out of the dental arch. I think another thing that contributed is her frenum. I think another factor is her periodontal disease.
And then just another question and another question. How would you, if she said, listen, doc, I'm really worried by the gray show through, by the gray show through at the number 6 implant.
Yeah.
What do you think you could do to address that?
So with a questionable prognosis, I think you will have a decent result with a subepithelial connective tissue graft. It won't be as successful as something that's with a favorable prognosis, but you should have some improvement. I think the extent of the improvement, you have to set expectations a little bit with the patient because with that implant in its current position, I can't change the gingival margin. Unfortunately, that's the margin that the implant's going to be at. It's always going to be higher. But if it's just the show through that's bothering her, I think we would get a potentially decent result with a connective tissue graft. Like you can appreciate this case here. It also had a questionable prognosis, and they got a decent result. It's obviously not perfect, but it was better than what they started with.
Yeah, I agree. And can you go back to that slice that we had through the number 6?
Yeah.
Sorry, the number 10 implant?
Yeah, absolutely.
The
Next one.
Yeah, it's interesting. It looks like she actually has.
It looks like she has a little bit of buccal bone here.
Yeah. So, in my experience, at least from what I remember, I don't know if we talked about this in clinic. At least from what I remember studying for my boards and what I see a lot in practice is, the scanner can't really pick up a certain thickness of buccal plate.
Yeah.
It's usually 0.3 to 0.5.
Yeah.
So I think you clearly have perforation of the implant through the buccal plate because you
Right.
almost see it
Right.
through the mucosa. But when you see something like this, it's not really a dead giveaway.
Absolutely, yeah, because when you have metal, as you know, you'll have an artifact on the CT. So yeah, the metal does kind of make you not appreciate the buccal plate. It could be intact. I think it wouldn't be, if this implant was in a good restorative position, it wouldn't be a bad idea to just raise a full thickness flap and evaluate. But because we also don't like the restorative position of this implant, I think it's better to explant that and start from scratch so we can put 10 and 11 together.
How would you manage this if she came back, if you did the GBR, beautifully, she had excellent primary closure, things were healing well, she came back at 4 months, and you had not enough bone in the 10th site, we had enough bone in the 11th site, because your treatment plan was an implant in 10, an implant in 11, or a bridge across the front. Let's say you only had enough bone in the 11th site, what would you do then?
It's not a bad idea to cantilever off like a lateral. You're not getting much forces on a lateral, but it depends on your school of thought because cantilever forces are also the worst kind of forces you can have on an implant, right? I mean, you have shear forces, cantilever forces contribute to that. So I think it would a little bit depend on your school of thought and how comfortable you feel with the cantilever. it's not a bad option.
Awesome. Thanks for helping me through that.
Thank you.
Great job.
Dr. Glazer?
Please, good presentation. Couple of things just to play off the last thing. If you were a cantilever, to combat the forces, you could put a distal rest on the number 9.
Okay.
Okay, and that'll eliminate some of the force of the cantilever and the lateral is not bad, even when you're doing just routine convolution.
Right.
But very often I put a distal rest. Go back to I agree with you on 8 and 9, it was extrusion. I don't agree with you that the freedom had anything to play in that.
Okay.
And the reason for that is typically when you have a low freedom, it would cause that
Right.
black
Right.
triangle. And one of the easiest ways to rule that out is if you lift the lip, and if you have a blanching of tissue between 8 and 9, that's a freedom pull.
Okay.
That will create the diastole.
Got it. I'll check that on her the next time I see her. Yeah.
Just one other consideration is, she has a very, very low contact point.
Yeah.
I mean, very, coronal contact
Yeah.
point. So, in addition to all the other factors, I think that part of the reason she has a black triangle is just how low the contact point is. So I wonder what you think about that.
She always had diastemas. I asked her next time I see her to bring some pictures of what she used to look like before so we can have a little bit of a baseline. Yeah. Anyone else? Thank you.
Our main speaker can talk. Pretty good. Barbara, you got some heavy shoes to fill here. Good job.
Thank you so much.
Curious if there's any questions in the chat room.
Oh, yeah. Bring them on.
What is it? Raise your hand or read them. Let's see, questions. No, what was that about?
We're sharing our screen. Stop that. What's going on?
What's going on? When am I going to get an image? I can barely
That was
hear
at
you.
7:30.
Are we still on? Okay.
Best presentation I've ever seen. There you go. Best presentation I've ever seen. Okay, so we are going to hook you up.
Yes.
And we're going to, what are we going to do after this? We're just going to keep this going and you're going to show, right?
I'm just gonna plug him. He's
Yeah,
on.
yeah.
Yeah, so this I could leave this.
He's online too.
Yeah, I could leave this.
Okay, cool.
Turn this on. Turn this on.
And share.
And share.
Good.
And share.
Just
I don't want There you go.
I usually don't even have to bother. Oh, okay.
Later. There we go. Now it should work.
Okay, so
Entire screen. Share. I'll restart the browser. Oh, no.
is not going to do 10 times as good a job. I think when it's such a low ROI to get.
Okay, there we go. All right, hold on. If we could just do that window.
All right, it's up. So if we were to put the PowerPoint up, because it's up on the screen.
Yeah, that's the thing. It's only showing this. It's this one.
That's it. Yeah, that's there.
You got grant access. Open system preferences. It's still making me do this. I have to restart the tab,
Even though it's up on the screen?
even though it's up on the screen.
Okay. You're the boss.
Okay, let's see if this works. Why is it making me do this? I just want to share the screen.
Yeah, I bought a bunch of folders on it. You wanted.
How's that going?
Not well.
How's that going?
It won't let me share the screen.
Oh, again with that?
Yeah,
Oh,
it's fine.
It's up there.
Go to. And maybe
So it
try
should be
this.
okay.
Try this also. Put it in again. You're not be able to open. So you quit and reopen. Okay. There we go. That's what we wanted the whole time.
Okay.
All right.
Okay.
You're all good.
I'm good.
Yes, sir.
Okay, so I'm gonna bring this up.
Yep.
Okay.
All right, we got it.
All right, so let me do the intro.
Oh, boy.
Okay, so our next presenter has been in the field of laser dentistry for over 33 years. Wow, that's a long time for lasers. CO2, Nd:YAG, erbium diodes. He's authored 16 papers, 6 textbooks. The list of all his textbooks, different languages. The peel technique for laser infant tongue and tie and lip release is so unique that it's been granted trademark status with the UK, United States, and Canada. He's taught thousands of dentists. Please welcome Dr. Convissar, right?
Good enough.
Convissar, Dr. Robert Convissar.
Thank you, thank you. I always like to know who I'm speaking to. So how many residents? Okay. They let you in the program at your advanced age? That's pretty good. I'll assume that everybody else is a general practitioner except oral surgeon? Oral surgeon? and GPs?
Yes.
Okay. No periodontists here? So we can make fun of periodontists in the next hour or two? Okay,
We
good.
would do that anyway.
Yeah, well, they deserve it. So my courses on laser dentistry are usually 16-hour workshops. So it's hard to distill that into about an hour and change. But this is a basic lecture that I give to the residents at the hospital where I teach. It's just a little bit about wavelengths, laser tissue interaction, how lasers work. Anybody here have a laser? What do you have? CO2, which one? Light scalpel? Oh. Okay. What do you have?
The DECA CO2, we have the, Jim.
Yeah, we just got the new Perio smart.
Oh, you got the DECA Periscope also?
Yeah.
Okay. Good. Okay. The oral surgeons, no lasers?
We used to use Epic
Oh, really? An oral surgeon is going to use an Epic Pro? Is an Epic Pro a laser?
It's a diode, right?
It's a diode. Is a diode a laser?
It's a light source.
It's a light source. Is it a laser? See, I'm from Brooklyn, so when you ask me questions, I'm going to ask you questions right back. And sometimes the questions that I ask may unfortunately embarrass you. That's not why I'm asking them. That's just an extra added thing that happens when I ask questions. So let me tell the oral surgeon a little bit. I like to tell oral surgeons things because they always tell us the implant failed because we left cement there when we know the implant failed because they put it in cockeyed, right? Okay. So who here knows who Gordon Christensen is? Okay. So let's, hang on. Let's make sure we have the audio plugged in. That would help. So let's hear what Gordon Christensen has to say. And for you residents, when you go out into the real world and you get a job and the dentist that hired you says, oh, we have a laser and it's a diode, you can look them straight in the eye and tell them they have no idea what they're talking about. I'm sure that will endear them to you.
What's your views on lasers?
This particular orientation of diode is basically in the 800, 900 nanometer range, and it basically is light going through at that wavelength through a fiber optic bundle, and the light will do nothing until you put, as you know, a black piece of burnt cork or articulating color on the tip. So if you send light through this fiber optic bundle and it's this black thing, what would it turn to? Heat. The diode laser is basically a large electrosurgery, a slow, large electrosurgery, making a cut, give or take 3/4 of a millimeter to a millimeter wide.
Everybody got that? So we have to talk about what a laser is and what a laser isn't. We'll talk about that in a couple of minutes. One of the two critical things you have to understand is that lasers never, ever, ever, underline the word ever, touch tissue. Lasers never touch tissue. If you're touching tissue with a laser, it's not a laser. So let's say we're ophthalmologists today. Now, ophthalmologists use diode lasers all the time for retinal surgery. So this is the eye. You see where the retina is all the way in the back. So if you believe that lasers are contact devices like a handpiece, like a scalpel, if you believe that lasers are contact devices, how would we do retinal surgery as ophthalmologists? I guess the only thing we could do is like take the laser and shove it in the back of somebody's eyeball if we're doing retinal surgery. I did that once on my mother-in-law. She screamed just a little bit, not too much. So lasers are non-contact. You never touch tissue with a laser. This is the way lasers work. The laser is a millimeter or more away from the tissue. The photons come out of the laser. We're not going to be able to show photons there. I'll show it down here. Okay? Photons. Just a powerful beam of light. That's all. They come out of the device. When they come out of the device, they're absorbed by the tissue. If they're not absorbed by the tissue, there'll be no therapeutic effect. If they are absorbed by the tissue, there will be a therapeutic effect. The problem with diodes is that diodes are not absorbed by tissue in the oral cavity. So what people have to do with the diodes is they put something black on the tip of the diode. That leads me to question number one. Why do we wear light colors in the summer and dark colors in the winter? Anybody? Say it loud. What does what? The white reflects. Okay, white reflects, black absorbs. So if you are in the summer and you're sitting on the beach, you want to wear something white or as light as possible because white will reflect all the sunlight and keep you cool. In the winter, as it approaches, the sunlight is very feeble. We want to absorb as much sunlight as possible. So we wear something black because black absorbs all light energy. White reflects all light energy. So if you have a diode device like an EPIC, not that I'm pointing fingers at anybody, if you have a diode device like an EPIC and you try and put it on tissue, absolutely nothing's going to happen to the tissue unless you put, as Gordon Christensen said, put something black over the laser tip. The black will do what to the photons? Photons are light energy. It will absorb all the light energy, prevent the photons from coming out, and turn that device into a hot glass tip. So, anybody here like to watch the Food Network? Oh, come on, somebody. Okay. Very, very difficult cooking question. What's the boiling point of water in degrees Celsius? 100. Everybody got that? 100 degrees Celsius, boiling point of water. When you're working on tissue, in order to vaporize it, you have to get the tissue temperature up to 100 degrees because oral mucosa is 70% plus water. So if you hit tissue that has a high water content with something that will heat the tissue up to 100 degrees, that tissue is going to be vaporized instantly. So you were using an EPIC for a while. Any idea what the tip temperature of an EPIC is? No idea. So you were sticking something in a patient's mouth and you have no idea what the tip temperature of that was. Is that right? Can I make more fun of him now? Or just, should I be easy on him? According to the peer-reviewed literature, not according to me, according to the peer-reviewed literature, the average tip temperature of a diode laser is 750 to 1500 degrees Celsius. The average tip temperature of an erbium, which is a type of laser, or CO2, which is a type of laser, is 100 degrees Celsius. So one of the things I do as a general practitioner is I work on 4, 5, 6, 7-day-old babies that can't latch onto mommy's nipple and nurse. I can remove the tongue tie with a CO2 or an erbium, which are lasers, which will remove the tissue at 100 degrees Celsius. Or I could use a diode at 750 to 1500 degrees Celsius and melt the tissue. What do you want me to use on your baby? Let's ask another question. I'm working on your mother-in-law. Diode? Okay. Okay. All right. Is my mother-in-law listening to this? Let me see. Ma? No. Okay, good. All right. Just checking. Okay. So let us start with laser dentistry 101, an introduction to wavelengths and laser tissue interaction. Disclosure, the most important slide of any presentation, whether it's a presentation like this or a presentation at the Greater New York, which is coming up, or a webinar, or just reading a journal article, you need a disclosure from the presenter. So over the past 34 years, I've received honor in the form of cash for discounted goods, supplies, equipment, materials, and devices from the following laser companies. Not too many, just a few, because I've been using them only for 34 years. There's the list. So virtually any laser that's out on the market is a laser that I have taught people how to use, I have consulted with the company, or otherwise played around with. For this presentation, I haven't received any money. I'm doing this as a free course for you people. Usually I do it for the residents at the hospital where I teach. I'm not an employee of any laser company, blah, blah, blah. I don't want to go through the whole disclosure, but let's talk about what you should learn from a good comprehensive laser course. And for the residents, when you go out into the world, you'll see that there are lots of laser courses, 99% of which are sponsored by one laser company. And there's just one laser company out there, one device, and that's it. And that type of course is going to skew all the information towards you buying that device. And that's not a good thing. I've taught somewhere close to 400 laser courses over the past 30 something years. And at every single one of my courses, we have a minimum of 3 to 4 different lasers, different laser companies. That's the only way to figure out what's going to work in your hands and work for your patients. So make certain, if and when you take a laser course, that there are at least 3 or 4 laser wavelengths there. Otherwise, you're just getting the company line. And make certain that the speaker is not being paid by the laser company. So what should a good comprehensive laser course look like? It should include all of these things: initial non-surgical periodontal therapy, working on the periodontal pocket, periodontal surgery like frenectomy and gingivectomy, regenerative periodontal surgery where we actually regenerate the periodontal architecture, we regenerate osseous structure, we regenerate soft tissue. Implantology, including peri-implantitis. There is a boatload of literature regarding laser treatment of peri-implantitis. There's a lot of information about that maybe we'll have time to share later today. Fixed prosthetics include smile design around laminates, gingival troughing, soft tissue crown lengthening, ovate pontic site preparation, removal prosthetics, pre-prosthetic care, pediatric dentistry, including orthodontics, neonatal dentistry, oral surgery, oral path, oral medicine, aesthetics, cosmetics, endo, practice management. A little thing about neonatal dentistry. Sometime in the next couple of months, I hope to sell my practice. And when I sell my practice as a general practitioner, I'm going to be opening up a new practice that is going to deal exclusively with working on infants. As a general practitioner, I enjoy making it all on 4. I enjoy, if somebody comes in with a toothache, I can do an endo and get them out of pain, or an extraction, get them out of pain. I enjoy putting in a mouthful of laminates, but there is absolutely nothing that I could do that gives me as much joy and satisfaction as when a dyad comes into my office, mother and child, and they're sleep deprived and they're crying, and mother has postpartum depression. Why does she have postpartum depression? Because at that stage in her life, with a 3-day-old, 4-day-old, 5-day-old baby, what is her one overriding thing to do? Feed her baby. And she can't feed her baby because the baby is tongue-tied. And the baby is getting up every 2 hours and attempting to nurse and can't nurse because the baby can't latch. And I do my magic, and they leave the office a little while later and they're crying again. Only it's tears of joy because for the first time ever, baby latched successfully onto mother's breast. There is nothing in dentistry that gives me as much joy as that. That's something that I give a 2-day course for. I'll be doing a course somewhere around here in a couple of months on that. I'll give you my email address if anybody's interested. It's really, in all modesty, a really fulfilling course. It's a great course. A lot of information you have to learn. Babies can die from that if you don't do it correctly. Babies can die if you don't do a good medical history. I don't know how much you know about vitamin K deficiency bleeding, but babies are born without vitamin K. And by day 8 or so, they start to make vitamin K. And if you do the procedure and the baby has not had a vitamin K shot, baby could bleed out. So there's a whole bunch of things to worry about. You have to worry about the family dynamics. A colleague of mine was working on a baby. It was a low educational mother and father. Father did not like the fact that baby was crying and crying and crying as a result of a tongue tie that wasn't done too well. And daddy took baby out of the crib and held the baby and said, "Stop crying, stop crying, stop crying," and put the baby back in the crib. And the next morning, the baby was dead with shaken baby syndrome, multiple hematomas in the baby's brain. So there's a lot of important things to learn. That's why it's a 2-day course. And if anybody wants to talk to me about that, I'll give you my email address later. You can contact me, you can email me, and we can discuss it. What else should be in a good course? Well, hard tissue procedures, anesthesia, preoperative dentistry. Is there really such a thing? Yes, of course there is. Osseous periodontal surgery, osseous crown lengthening, desensitization. I do 100% of my operative dentistry on deciduous teeth, 100% of my operative dentistry on deciduous teeth with my high-speed handpiece with no injection analgesia. I pre-treat the tooth with a PBM laser. So that's another thing. That's another 3-hour course for another day, talking about PBM lasers. And of course, critically important, the correct way to use lasers in periodontal pockets. Far too many dentists do it the wrong way. The American Dental Association, the American Academy of Periodontology, and other organizations have come up with clinical practice guidelines regarding the use of lasers in periodontal pockets. And it says essentially, don't do it. And you have bazillions of dentists throughout the United States doing it, and they're violating clinical practice guidelines and they're violating standard of care. And one of the things that I do is I act as an expert witness in malpractice cases when dentists do stupid things with lasers. And unfortunately, there's no requirement to get trained in laser dentistry. So a lot of dentists out there do stupid things with lasers, and then we have to try and defend them. And usually we cannot, because when you violate clinical practice guidelines and standard of care, there's not much we could do to defend you. So there's a lot of stuff. And of course, PBM lasers, something we really don't have time to discuss today. PBM lasers are just one of the most wonderful devices that's out there. A 1-hour course won't give you enough information to use your lasers. You need a good full 2 days of laser dentistry education. Anything less won't give your patients the best treatment, the treatment that they deserve. So what procedures should you expect to perform on animal jaws during a good comprehensive laser course? One of the things we do, of course, is we'll bring in pig mandibles, and we expect every single dentist at the course to perform a biopsy, gingival troughing, periodontal pocket disinfection that does not violate clinical practice guidelines, hemostasis out. There's also treatment, frenectomy, gingivectomy, flap surgery, spot size and hand speed demonstrations, endodontic canal disinfection, operative dentistry. And if you take a course and it doesn't include all of this, you're not getting your money's worth out of the course. Courses must be a minimum 2 days, otherwise they're skipping things. So laser dentistry 101 can be summarized in just a couple of slides. First question, tomorrow morning I'll be going to my dentist for some x-rays. What will my dentist be putting on my chest and thyroid? A lead shield. Why? Scatter? Close but no cigar. Anybody else? Okay. What does black do and what does white do? Black absorbs all laser energy. White reflects all laser energy. The lead shield is put on because ultraviolet radiation, such as X-rays, is absorbed by metal. So if I put a lead shield on and I'm shooting X-rays, the X radiation will be absorbed by the lead shield, won't get to my body. So always think of absorption or not absorption or reflection. Why do people wear light colors in the summer, dark colors in the winter? We went through that. The mnemonic device you're going to learn is RATS. Reflection, absorption, transmission, scatter. Those are the 4 types of laser tissue interaction. Reflection is of no concern, except if you're not wearing the right safety glasses and you get hit in the eye with a laser beam, in which case you'll end up with a corneal abrasion or a retinal tear. Reflection is not therapeutic. Absorption is what gives you a therapeutic effect. You want to have a maximum amount of absorption. Transmission, the laser energy goes right through without any effect whatsoever on the tissue. Scatter, there's a little absorption, a little transmission. Scatter is only important if you're curing composites with a laser, which we do, or if you're using a PBM laser. Everything in dentistry, everything in light tissue interaction, everything in lasers is based on RATS. RATS. Reflection, absorption, transmission, scatter. Lasers are nothing more than highly focused beams of light energy. So physics doesn't lie. I could spend 2 hours alone on this. So let's talk about periimplantitis for a minute. So we have the ultraviolet part of the spectrum, visible part of the spectrum, infrared part of the spectrum. Ultraviolet, ionizing radiation, carcinogenic radiation, very dangerous. That's why we've got to protect ourselves with a lead shield. As the wavelength gets longer, the amount of energy in the wavelength gets shorter. Then we're into red, orange, yellow, green, blue, indigo, violet, part of the spectrum we could see. Past the visible part of the spectrum, we're in the infrared part of the spectrum, non-ionizing, non-carcinogenic. We have a lot of lasers here and longer wavelengths. We have microwave, AM radio, FM radio, TV, shortwave, and way, way, way over here, if you've ever been to an airport, you've gone through a millimeter wave detector. That's the thing that the TSA uses for security at all the airports. So that's the electromagnetic spectrum. Two things you need to know from this. The shorter the wavelength, the higher the energy. As we go from left to right, as the wavelength gets longer, the amount of energy in the wavelength gets less and less and less and less and less. So short wavelength, like X-rays and cosmic rays in space, very high energy. Long wavelength, less energy. Longer wavelength, less energy. Longer wavelength, less energy. And then we have all the way out here, CO2 at 10,600 nanometers, which is a ridiculously long wavelength, which means it is a ridiculously weak wavelength, extremely, extremely, extremely weak. CO2 is the #1 wavelength in the world for medicine and, of course, dentistry. John McCain, Ted Kennedy, other patients that have died of malignant glioblastomas. How did they remove the glioblastomas? CO2 lasers. Spine surgery, CO2 lasers. Most ENTs that use lasers, CO2 lasers. Colon and rectal surgeons use a variety of wavelengths, among them CO2 lasers. OBGYN, vascular surgeons, CO2 lasers. So why is it that CO2 laser is a ridiculously weak wavelength because it's such a long wavelength, but it's the #1 wavelength in medicine and the #1 wavelength in dentistry? The answer is really simple. We don't care how much energy is in the wavelength. We only care about rats. We only care about absorption. And I'll show you in a couple of minutes, of all of the wavelengths that we have, the CO2 is the best absorbed by oral mucosa. Doesn't matter if it's strong or weak. If it's absorbed really well, it's going to give you a therapeutic effect. Make sense? Good, because I just made that up a minute ago, but that's okay. Okay. So what determines rats? What determines reflection, absorption, transmission, and scatter? Two things. The wavelength that shoots out of the laser and the chromophore of your target tissue. Everything we do in laser dentistry is based on one thing, chromophore. Once you understand chromophore, backwards, forwards, sideways, up and down, in and out, you'll understand everything about laser dentistry. Everything is based on chromophore. How do we discuss chromophore? Very simple. Why do we wear white colors in the summer? Why do we wear black colors in the winter? Absorption, reflection. Chromophore means there's something that's causing the absorption or something that's causing the reflection. I'll give you a better textbook definition. Chromophore is a light-absorbing compound or molecule normally occurring in tissues that absorb specific wavelengths of laser energy. There are 4 main chromophores in the oral cavity. Water is #1 because oral mucosa is minimum 70% water. Hydroxyapatite, bone, enamel, dentin, cementum. Hemoglobin, oxyhemoglobin, because the oral cavity is very, very vascular. And melanin. Melanin is an interesting chromophore. The first thing that people want me to teach them when I get off the plane in Dubai and Bangkok and Tokyo and India isn't how to use the laser for gingivectomy or frenectomy or soft tissue crown lengthening or anything like that. The first thing they want me to teach them is how do you bleach gingiva? How do you depigment melanotic tissue? Because in many cultures, having deeply pigmented, heavily melanotic tissue is a sign of being kind of lower class, not pretty, not handsome. So that's one of many, many, many things that we can do with a laser that you really can't do with a scalpel. I mean, there are dozens and dozens of papers that have shown using scalpels for melanin depigmentation, and it's uncomfortable and doesn't work terribly well, and it grows back really quickly. And I can take my laser and go like this on someone that's got heavily pigmented, heavily melanotic tissue, and I can bleach their tissue coral pink. And it's a great procedure for a couple of reasons. Number one, it's not covered by insurance, so it's cash on the barrelhead. That's always a good thing. And it's a repeat process because it lasts a couple of years, unless the patient is a smoker, in which case it's going to last significantly less than a couple of years. So you get repeat business. So in order to maximize your laser, you must completely understand the concept of chromophore. So let's say we're ophthalmologists again. If I'm doing some corneal surgery, I would use a CO2 or an erbium. If I'm doing retinal surgery, I would use an Nd:YAG or a diode. Why? Whenever I ask a question, the answer to the question is always going to be chromophore. CO2 and erbium are absorbed by the cornea. The cornea has a high water content. The chromophore for CO2 and erbium is water, which means CO2 and erbium are absorbed by watery tissue. So if I'm working on any tissue that's got any amount of water in it, CO2 and erbium are going to be absorbed by it really, really well. Nd:YAG and diode don't care about water content. They care more about specific color of tissue. So Nd:YAG and diode will go through the cornea, the lens, the iris, the sclera, the anterior chamber with the aqueous humor, the posterior chamber with the vitreous humor. Will go through those 6 tissue types with no effect whatsoever on those tissues because those tissues don't have the correct chromophore. And then those wavelengths will ultimately be absorbed by the retina because the retina has the correct chromophore for those wavelengths. So everything in dentistry is based on chromophore and also chromophore. So how many wavelengths do you see up there? Easy question, right? Simple question. How many wavelengths do you see up there? Somebody shout it out. 4. How many say 4? Everybody raise your hand if you say 4. The resident that did the presentation is saying, no, it's not 4. How many do you see? There are 9 wavelengths out there. Yeah, 9 wavelengths. Saying the word diode is like saying the word car. When I leave here in a little while, I could go back to Long Island in a Yugo, for those of you that remember what a Yugo is, or a Volkswagen Beetle, or I could go back in a Rolls-Royce Silver Spur. They're both cars, but how you get from point A to point B is very different. So saying the word diode means nothing. Diodes can emit at 810 nanometers, diodes can emit at 940 nanometers, diodes can emit at 980 nanometers, diodes can emit at 1064 nanometers. That's the wavelength. Each wavelength is a little bit different. Each wavelength is going to have slightly different effect on tissue. CO2 comes in 2 flavors. 10,600 nanometers is the conventional wavelength that has been around since 1964. The CO2 laser was invented by Dr. Patel in 1964. And then we have a newer wavelength at 9,300 and 9,600 nanometers. Erbium comes in 2 flavors, erbium YAG and erbium chromium YSGG. Those are lasers that are used for hard tissue. And then we have the Nd:YAG. So we have 9 wavelengths there. Diodes are used for soft tissue only. They have no effect on hard tissue. If you use them on hard tissue, you'll cause crazing, cracking of the enamel, dent, and cementum bone. Nd:YAG, soft tissue only. If you use it on hard tissue, crazing, cracking, charring of hard tissue. CO2 10,600 is for soft tissue only. The CO2 at 9,300 and 9,600 nanometers is for soft and hard tissue. There's only one such animal in the world. It is a laser that you will probably see lots of ads for, or may have seen ads. The name of the unit is the Solea, S-O-L-E-A. It's made by Convergent Technologies. It's a rather large unit, and it works for hard tissue and soft tissue. That's the good news. The bad news is fully equipped, it costs about $150,000. It's also kind of large. Erbiums, there are two erbiums on the market, the Waterlays BioLays and the Fotona Light Walker. And those are about $70,000 and up. And those are for soft and hard with a big butt. They were invented for hard tissue. They can be used for soft tissue, but are less than ideal for soft tissue. And the reason is something I took out of a medical textbook, a plastic surgery dermatology textbook. And this talks about the depth of penetration of different lasers. And you see at the very end, you have CO2, which when you use it on tissue, penetrates to a depth of 20 microns. So I can make 20 micron slices with my CO2 laser. Erbium is even better absorbed. It's absorbed 2 microns at a time. So that seems really good, really conservative, except nobody wants to make an incision 2 microns deep. You need to make incisions considerably bigger. So erbium will be very conservative, but of course it will take a much longer time to do so. And then of course we have Nd:YAG, which the two of you now have, which when used can penetrate up to 4,000 microns. And diodes can penetrate 3,500 microns. So everybody that lectures on lasers has a couple of slides with a lot of squiggly lines. The green squiggly line is absorption in water. The red and blue squiggly lines are absorption in hemoglobin and oxyhemoglobin. So water about 75% concentration, which is mucosa. Hemoglobin and oxyhemoglobin at the correct concentration, what we have in blood. And we see that erbium and CO2 very, very highly absorbed in water, which is great because, or mucosa, 70-75% water or more. So those wavelengths are going to cut soft tissue, mucosa very, very well. Diodes, not well absorbed at all in most things. That's why we don't use them as lasers. That's why we have to put something black on the tip, turn the tip into a hot glass tip, and melt tissue at 750 to 1500 degrees. The difference in absorption between a CO2 and a diode is 1,000 times. CO2s are absorbed 1,000 times better in soft tissue than diodes are. So most dentists have diodes. Diodes are the most popular lasers out there because you can buy a diode for $5,000, whereas a CO2 is going to be $40,000. But once again, a CO2 is going to cut tissue at 100 degrees Celsius, and a diode is not going to cut tissue. A diode is going to melt tissue at 750 to 1500 degrees Celsius. Doesn't mean you shouldn't use it. It means you need to know how to use it. So oral mucosa is 79% water. CO2 and erbiums are best absorbed by water. Diodes are not absorbed by water, not absorbed by oral mucosa. That's why we turn them into, as Gordon Christensen said, into hot glass tips. Most people don't realize that. They don't understand it, and they don't understand the best way to initiate it and make it work, unfortunately. So what do we do to make them work? We initiate them. In order to answer that question, we need to answer this question: what is a laser? There are two definitions of what a laser is. First is it's a device that produces a beam of collimated monochromatic coherent light. The other definition is it's a device that emits a beam of collimated coherent monochromatic light. So my pointer here is a laser. It's emitting a beam of collimated coherent monochromatic light. But if I go like this, it really isn't a laser because it's not emitting. It's producing, but it's not emitting a beam of collimated coherent monochromatic light. How do lasers work? For virtually every medical specialty, lasers work by emitting a beam of collimated coherent monochromatic light. So true lasers, devices that work as real lasers, emit photons. True lasers are photon emitting devices. We're going to get to some clinical stuff in a little while. I just want to give you a little bit of a background because once again, as you go into the world, you're going to see lots and lots and lots of offices where people are using diodes for all sorts of things And my experience is 90% of the people that use diodes, number one, don't know that they're really not lasers, they're just hot glass tips. Number two, they don't know how to minimize thermal damage to tissue, and that's when they end up in court, and that's when we end up trying to defend them, and more often than not, we cannot. When a laser device is turned on, it produces a stream of photons. When that stream is emitted, and here's my stream of photons, it's how these photons interact with the tissue that will give you a therapeutic effect. Specifically, it's how these photons interact with what? The chromophores of the target tissue. Now, chromophore is important. You think oral mucosa is oral mucosa is oral mucosa? That's not true. He's neurotic. He flosses 4 times a day, brushes 3 times a day. He's a slob. He brushes once a month, flosses every New Year's Eve, and his tissue is red and hyperemic and edematous as opposed to his, which is fibrotic. We don't have any African Americans here. African Americans would have heavily melanotic tissue. So you take a laser. Laser is absorbed by what? By the chromophores of the target tissue. So a lot of lasers have presets. I always get into trouble when I say this, but I'm going to say it anyway because I'm from Brooklyn. I like to get into trouble. Presets are for monkeys. I can teach anybody to use a laser if there's presets on it. Presets are the worst thing in the world. Because let's say I'm doing a gingivectomy on him, and a gingivectomy on him, and a gingivectomy on an African American. Totally different chromophore content. Can I use the same settings on each of them? Hell no. Most people don't understand that. And that's when they get into trouble. So everything we do in laser dentistry, once again, is based on chromophore and also chromophore. So let me skip through some of this. So are diodes really lasers? Yes and no. Yes, they produce beams of collimated coherent monochromatic light. They don't emit beams of collimated coherent monochromatic light. They are lasers. They're just not used as lasers. They're used as hot glass tips. Got it? Questions? Everybody awake? Okay. So that's Gordon. We can skip through this. Okay. Let's do a couple of clinicals. Adult tongue tie release. Anybody here ever do an adult tongue tie release? You two don't have to answer. Okay. Tongue ties. Why do we do tongue ties? On adults, on adolescents, speech pathology problems, digestive problems, sleep apnea, snoring, all sorts of things like that. So the field of dentistry changes ridiculously rapidly. Graduated from dental school. Those of us who are old enough use that word, escape. 43 years ago, 95% or more of the procedures that I perform, of the techniques I use, of the materials I use, weren't even a pipe dream 40 years ago. Implants? There's a lunatic by the name of Norman Cranen who was doing implants decades ago, and Leonard Linkow, who was taking a blade and hammering a blade into a mandible. And if you want to look at something really awful and disgusting, you can Google Norman Cranen, C-R-A-N-I-N, and his subperiosteal implant. What he would do is he would take a scalpel, edentulous mandible or maxilla, open up from ear to ear, flap everything open, take an impression, cast something, seat it on the bone. It would have a couple of projections on it, suture everything over. That was called a subperiosteal implant. And he had a lot of successes, and boy, did he have a lot of failures. Dr. Leonard Linkow, who was an early implantologist also, had implants that looked like blade. They were called blade vents, was one of them. And they would literally make an osteotomy in the bone, and then they'd hammer the implant into the bone. So there was a lot of stuff that was done in the dark ages. There's a million and one reasons for tongue ties. There is a statistical correlation not a cause and effect, hasn't been proven yet, but there's a statistical correlation between infants with lip ties and tongue ties and sudden infant death syndrome. Does that wake anybody up? When babies are horizontal, if they're tongue tied, the tongue goes into a retruded position, closes off the airway significantly enough that the baby is in a deep sleep, doesn't wake up and dies. Every baby that is tongue tied, that is not corrected, turns into an adolescent that is going to need rapid palatal expansion and is going to have lower anterior crowding. Why? The tongue is a very powerful muscle. The tongue is responsible for growing the face in 3 dimensions. 1, 2, 3. If the tongue is tied, the tongue can't move everything. When the deciduous teeth are lost, when the adult teeth come in, where do the adult teeth come in? They come in lingual to the deciduous teeth. How do they magically move from where they start out to where they end up? Tongue helps move them. The tongue helps form the mandible anteroposteriorly, mesiodistally. Rapid palatal expansion. Most babies are born with a V-shaped palate. What's the purpose of the tongue? When it elevates, it helps smooth down the palate into a U-shaped palate. Babies that are tongue-tied, V-shaped palate, they end up with rapid palatal expansion. If it's not corrected, you always hear, oh, my baby's a picky eater. Yeah, that's not true. Babies are like dogs. Anything that falls on the floor goes right in their mouth. Babies aren't picky eaters. Babies can't masticate certain food textures. Give somebody that's tongue-tied mashed potatoes, they can't clear it from their tongue. Give them a French fry, same taste, that they can chomp on easily. It's not the food, it's the texture. Go to a Baskin Robbins, go to a Carvel, go to an ice cream shop, and watch people eat ice cream. People that are not tongue-tied will lick the ice cream cone. People that are tongue-tied, they can't do that. They can't extend their tongue. So what do? The ice cream is here, and they dab it on their tongue. I dare every one of you to stand outside a Carvel or a Baskin Robbins for 20 minutes and watch people. And if you're there for more than 20 minutes, I have a feeling they're going to call the cops and say there's somebody strange watching everybody lick their ice cream cones. But let me show you an adult tongue tie release. One of the good things about living in the 21st century is we have YouTube. One of the most horrible things about living in the 21st century is we have YouTube. Dentists post such ridiculous things on YouTube. That's gross negligence and malpractice. I did a tongue tie release and it only took me 4 minutes. Well, a tongue tie release should take 15 seconds on a slow day. So let me show you what a tongue tie release looks like. You know the floor of the mouth is very, very vascular. Look at all the bleeding on the floor of the mouth. Look at all that blood. Anybody see any blood? Now you notice what he did was I said, stick your tongue out all the way, all the way, all the way. And he stuck it out to the Vermilion border. And he stopped. Why? Because that's all he could ever do. He never knew he could do anything more. And I keep on saying him all the way, all the way, all the way. So after he stopped and he heard me go all the way, then it went all the way down to his chin. Let me show it to you again real quickly. Questions, questions, questions? Who's got questions? So where do you get these patients from? Well, I have pediatricians that refer to me. I have lactation consultants that refer to me. I have speech and language pathologists that refer to me. I have vocal coaches that refer to me. I had a budding opera singer a couple of weeks ago. The opera singer coach said, "You're a very good opera singer. You'll never be at the top of your form because your tongue is tied." See, he stops and then it goes. Fast, easy, simple. Take a scalpel to the floor of somebody's mouth and see how much blood you get. Question. Anesthetize. It depends on who the patient is. If it's a patient that pays and doesn't cancel a lot, and yes. If it's my mother-in-law, I'm usually out of anesthetic that day. Yes, absolutely, and I'll show you that because that's the next slide. Depending on the thickness of the tongue tie and depending on the patient, you may be able to do it with topical or you may need to inject them. If you have some heavy duty topical, you could put it on that area by the box, or where those 2 hours are, 3 or 4 drops, literally 3 or 4 drops, and that's that. And that's more than enough. And you get 0 bleeding whatsoever. Cut through it, and that's that. Why tongue tie release? Sleep apnea, snoring, speech difficulties, food texture issues, posture and muscle issues. You'll know somebody's tongue tied when you watch people who are not tongue tied. Their head is in alignment with their spinal cord. People that are tongue tied, head is forward, shoulders around it. You'll see people, their heads a little bit more forward and their shoulders a little more. Who here fits that description? Bring the laser on left. Why? The tongue tie is fascia. Fascia is a continuous band of tissue that goes from the dura mater, the pia mater, the oxa mater. I thought that was funny. The dura mater, the pia mater, the arachnoid. It takes them a minute. They're just resonance. All the way down to your plantar fasciitis. Your plantar, okay? So when there is a tremendous pull of the fascia, it affects the sternocleidomastoid, affects all the muscles in the back, and they're always a little bit forward, and the shoulders are a little bit rounded. So this is a bodybuilder. That's pre-op. 15 seconds later. Can't get to the roof of the mouth, can get to the roof of the mouth. Pre-op, he can only get his tongue to the vermilion border. Post-op, all the way down to his chin. Stick your tongue out, roof of the mouth, all the way up as far as you can. Okay. Stick your tongue out as far as you can, right now. Okay. Stick it up to the roof of your mouth again. 15 seconds later. Now everybody's going to go home and look in the mirror. 15 seconds later. All the way up to the roof of the mouth. Look at that. That's beautiful. Stick it all the way out. Stick it up to the roof of the mouth. All the way up, 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 up. Beautiful. So when I graduated from NYU back in the dark ages, the amount of pediatric dentistry I did in the pedo clinic was a little bit less than this. To this day, after 43 years in private practice, I have not done a stainless steel crown or a zirconia crown on kids. When I left NYU, I did a 1-year GPR in a VA hospital. Youngest patient I saw was 18. No pedo. Went into practice in Manhattan, and in Manhattan, everybody sees the pediatric dentistry. So the amount of pedo that I did was essentially 0. And then I started working on 5-day-olds and 6-day-olds and 7-day-olds. Very, very different. And if somebody had said to me 20 years ago, "Hey, Dr. Bob, the most rewarding part of your practice would be working on 1-week-old babies," I'd say, do me a favor, give me what you're smoking, because it's got to be powerful. Would never have imagined that the practice would have gone in this way. So let me show you a tongue tie release quickly. Take a look at this baby. That is my finger with some of mommy's breast milk on my finger, and the baby is not maintaining a suck. You see the baby's coming off of my finger? Take a look at the midline, right smack dab in the center of the upper lip. What do we have? We have a lip blister. Take a look at what the lip looks like. Take a look at the nares. You see the baby's nostrils are flaring. Why is the baby's nostrils flaring? Because he's working so hard to try and suck and is using up so much oxygen that his nostrils are flaring. You always hear mommy say, oh, my baby's a wonderful baby. My baby's just a month old and is sleeping 5 hours. That's not a good baby. That's a sick baby. Babies should get up every 3 hours to nurse. And if they're sleeping more than 3 hours, it means that while they're up, they're nursing so inefficiently that they're exhausted and they sleep for longer. So I'll show you this baby 15 seconds later. So look at the nostrils flaring. Look at the lip. Look at the midline lip blister. Look at him coming off of the finger. A couple of seconds later, nostrils are not flaring. You don't see the lip blister. Look at what the lip looks like. Holding on to my finger, holding on to the suck. See the tongue tie right there. And that's immediately after. There's a whole lot of important things on this, but I don't want to go through all this. I don't want to bother you. But I want to tell you about one case. Not that I want to make fun of pediatricians, because we're in a medical center filled with pediatricians, and my daughter's a pediatrician, and I love her. But sometimes pediatricians could spend a little time with dentists and learn a little something. So this happened to a colleague of mine. Baby was not doing well. Baby was failing to thrive. Baby was not gaining weight. Baby was doing very, very poorly. Baby's lactation consultant, mommy's lactation consultant, said, I think there's a tongue tie. Baby was doing so poorly that they ran the baby into the emergency room because the baby was losing weight. Baby was dehydrated. So they hooked the baby up to an IV, gave the baby IV fluids. And mommy said, you know, Dr. Pediatrician, I think my baby has a tongue tie. Whereupon the pediatrician said, there's no such thing. No such thing as a tongue tie. Somebody told you a tongue tie because the dentist bought a laser for $50,000, $60,000 and wants to make money doing all sorts of procedures. No such thing as a tongue tie. Nothing wrong with the baby. We'll just rehydrate the baby and the baby will be fine. After a couple of days, baby was still doing poorly. Baby was sent to one of my colleagues and he did an oral exam. I'll show you the results of the oral exam. The baby was leaking milk orally. Babies should never leak milk orally because if there's a good seal to the nipple, shouldn't be any leakage. Shouldn't be any spit up. Why is there spit up? If there is no tongue movement, there's a space there between the nipple and the palate. Air comes in along with the milk. The air's got to come out one way or another. Baby is either going to be very flatulent or it's going to spit up a lot. The air comes out and milk comes out. So anyway, the baby was sent to one of my colleagues because they thought maybe the baby had a tongue tie. Even though the pediatrician said, no, no such thing as a tongue tie. Absolutely no such thing as a tongue tie. So my colleague did an exam of the baby. And why was the baby leaking milk nasally? How many healthcare professionals did the baby see at 1 week old? And the baby's leaking milk nasally. Nobody caught it. That's kind of frightening. Medically compromised patients. There are 3 classifications of drugs that do this. Dilantin, calcium channel blockers, cyclosporin. Okay, residents, this is for you. Is this tissue healthy or diseased? Healthy or diseased? How many of you say disease? Raise your hand. How many say healthy? Raise your hand. How many say, I'm afraid to answer because Dr. Bob's going to make fun of me? Perfectly healthy tissue. It's pink, stippled, fibrotic, perfectly healthy. What's the problem? Too much of it. Perfectly healthy. How's her home care? Her home care is better than me, better than mine. Pre-op, immediately post-op upper. 1 week post-op upper, immediately pre-op lower. Immediately 1 week post-op upper, immediately post-op lower. 2 weeks upper, 1 week lower. Pre-op, post-op. Is that beautiful? Is that wonderful? Can I have a round of applause for how wonderful and talented I am? I'll tell you a secret, but don't tell anybody. I didn't do this case. This was done in August by one of the residents at my hospital. I was standing over him, telling him what to do and how to do it. But this is the results a resident got. 1, 2, CO2. Couldn't do this with anything else. An erbium would take 3 years. A diode would fry the tissue. Couldn't do it. So we talked about chromophores. Pink versus red, fibrotic versus edematous. Got to change the settings. So when I say presets are the worst things in the world, you know what? They're pretty terrible. Because if you do both of these patients with the same preset, one's going to come out great, one's going to come out awful. Questions? Questions? Okay. What time am I going till? Because I can go till 3 o'clock in the morning.
We have you down till 9:30. I think you start on time.
Okay. Let's see what else we got. Okay, that I don't have the complete. Yeah, okay. Pre-op. Let's talk about a frenum. Let's talk about this. There is no attached gingiva on that central incisor, right? Plenty of attached gingiva everywhere else. No attached gingiva on that central incisor. See a nice frenum pull. I'm going to magically create a whole band of attached gingiva on this patient. This is pre-op. This is 1 week later. Big pull, no attached gingiva. Lots of recession. 1 week later, no graft, because I'm not talented enough to do free gingival grafts. Look at where the gingiva is now. How do I know it's 1 week post-op? Because that's what the wound looks like at 1 week. Whole band of attached gingiva. Pre-op, this is a patient that had terrible perio problems on the palate of these upper anteriors. The upper anteriors, 8 and 9, the occlusion was on the cingulum of these teeth. Deep overbite, 8 and 9 were walking out of the mouth. They were walking out of the bone. So my colleague did a flap on the palatal, tried to get rid of some of the pockets on the palatal. She also did a little frenectomy in my office. And the frenum was removed, and the patient came back a couple of months later for her recall, and the teeth had grown together. No Hawley. Does anybody even know what a Hawley is these days? No Invisalign, no Clear Correct, just 1 to 2, remove the frenum, and that was it. And if I'd known this was going to happen, I would have charged the patient another $1,000 for minor tooth movement. No bonding there. Oh, on that, just a little bit, yeah. So, hand speed, we can not talk about biopsy. You will see lots and lots and lots of patients with little irritation fibromas. They've got calculus bridges. When their tongue is addressed, it rests on the calculus bridge. They get these little irritation fibromas. Don't send it to the oral surgeon. Why make them rich? They talk about you behind your back and say, that implant failed? Oh, I used that already. Yeah, let's not go there. I'll think of something else. To do this, to here, in 1 minute or less with a laser, doesn't affect their speech, doesn't affect their chewing, doesn't affect anything whatsoever, and it grows in perfectly. And what else can we do on this patient? It's a nice little hemangioma here. We're going to remove that with a laser. Patient's in her second trimester of pregnancy. What's the diagnosis? Pyogenic granuloma, right? Everybody agree? Pyogenic granuloma. Raise your hand if you say it's pyogenic granuloma. Come on. Nobody wants to raise their hand. Okay. The diagnosis is you have no idea because you don't have X-ray vision. That's why you biopsy. That a good lesson? Good lesson. Don't assume. Don't assume. I'm the youngest of 10 first cousins. I have a lot of aunts and uncles. I have a lot of first cousins. I'm the youngest of the 10. The oldest of the 10, I'm very, very close with because I'm like a baby brother we never had. He got married to a wonderful woman. A couple of years later, they had a beautiful bouncing baby boy. Easy pregnancy. Everything was fine. Baby's 3 years old. Gets pregnant again. Terrible pregnancy. Horrible pregnancy. All sorts of GI problems. All sorts of symptoms. And the OB said, well, we can abort and do a whole workup, or you can deliver, and then we'll do a workup. And she said, no, I'd rather deliver. I'd rather have another baby, and then we'll do the workup. So she delivered, and less than a year later, she was dead of colon cancer. So they were thinking maybe the baby is pressing here, pressing there, the baby's in a weird position, and that's one of the reasons all the GI problems and all that. No, it was colon cancer. So when you see something like this, you can think it's probably a pyogenic granuloma. May not be. You know, the incidence of oral cancer is significantly higher than in the past. We all know why. HPV, human papillomavirus, right? The good news about HPV-induced oral squamous cell carcinoma is that it is more amenable to chemo and radiation. But the incidence of oral squamous cell carcinoma is really increasing. So if I have two patients, one's a 75-year-old guy, married his high school sweetheart, been married for 50 years. I see a lesion in his mouth. I have a 35-year-old single stockbroker, find the same exact lesion in his mouth. Who am I more worried about? I'm more worried about the 35-year-old. Why? Because the 75-year-old has been in a monogamous relationship for 50 years, and he really doesn't drink, and he gave up smoking decades ago. And the 35-year-old stockbroker goes to a cigar bar a couple of nights a week, has a couple of scotches along with the cigars, and has unprotected sex with more people than I have hair on my head. How do I know this? I'm like his barber. He sits in the chair and tells me way too much information. And he probably has an HPV-induced lesion. So don't think that when you're looking at somebody who's 35, 40 years old, that, that can't be oral squamous cell carcinoma. Well, it can be. Absolutely can be. And if you don't look, somebody's going to die. What time did you get up this morning? 7, 8, 9, 10, 11, 12, 1, 2, 3, 4, 5, 6, 7, 8, 9. You've been up 14 hours. How many people died in the United States of oral squamous cell carcinoma since you got up this morning, 14 hours ago? Anybody know? 14. One person every hour of every day. One person every hour of every day dies of oral squamous cell carcinoma, right?
Sounds right. Sounds right.
Yeah, that's right. I counted. But you know what this was? You have any idea what this was? Yeah, it was a pyogenic granuloma. We didn't know that. Here's a little bit of propaganda from a laser company. Just how they uncover implants. Why is there something white there on the floor of the mouth? To protect the floor of the mouth, because white reflects everything, so the floor of the mouth won't accidentally get hit with the laser energy. Nice and easy. So this is my friend Manfred's case. Manfred is clinically insane, but I'll never tell him that because he's 6'3" and outweighs me by about 60 pounds. So we got a problem there. Manfred is a brilliant dentist, a brilliant implantologist, a brilliant laser surgeon. What's he going to do? He's going to open that up with his laser, He's going to remove all the diseased tissue. It's going to look like that. What would any sane person do? Remove the implant, not Manfred. Because Manfred knows the electromagnetic spectrum. He knows ultraviolet, visible, infrared. He knows short wavelength, high energy, moderate wavelength, moderate energy, long wavelength, low energy. He also knows that when people come to his office and he exposes them to ultraviolet radiation, that the lead apron absorbs the laser energy. So he also knows that there's an inverse relationship between wavelength and absorption in metal. Short wavelength, high absorption in metal, long wavelength, no absorption in metal. So if this is my implant, I can take my CO2 laser with a wavelength of 10,600 nanometers, hit that implant with that laser energy from now until you finish your residency program. That implant will not increase in temperature, one iota. Why? Chromophore and rats. Reflection, absorption, transmission, scatter. The CO2 is reflected 100% by metal. No absorption of metal. Reflected right off the bat. So what Manfred's going to do is he's going to clean this up. He's going to get rid of the diseased biomatter on the implant. How? Using the CO2, because the CO2 is going to be well absorbed by the biomatter. The key to this is 360-degree circumferential access to the disease. He will then clean out the crypt. He will then stimulate it, get a little bit of bleeding, put in a bone graft, deepithelialize the inside of the flap, suture it down, deepithelialize the outside of the flap. 2 years post-op. Took a full 2 years, but he got 100% regeneration. Took 2 years. And we got plenty of cases like this. And we've got plenty of literature like this. Happens every day. Have you done many cases of periimplantitis, perimucositis? Works well. Some. When does it not work well?
Depends on the type of defect.
Depends on the type of bony defect. Also depends on something that nobody pays enough attention to. Occlusion.
Yes, there's a lot of factors, sure.
That's one of many factors. Periimplantitis is a multifactorial disease. But one of the big problems, and I'm not going to say they put it wrong, I won't say that, I've been there already. But one of the big problems with periimplantitis, perimucositis, is a lot of excursive contacts on that implant, right? Gotta make sure the occlusion is perfect. Take some courses on occlusal equilibration. It will serve you very, very, very well. Occlusal equilibration, at least in my hands, is one of the most difficult things a dentist can do. So you get a good equilibrated occlusion. You have a good osseous foundation, and you can get things to heal. Not all the time, but some of the times. Yes, sir.
On top of the reflection, I don't know if this is kind of there in your talk, but can you speak to the appropriate eye protection with CO2 laser use?
Sure. When I use a CO2 laser, I use my loops. That's it.
So like glass loops.
Yeah, my loops. They must have side shields. They must have side shields because you don't want accidentally having the laser energy come in this way.
Yeah.
Every laser is a specific wavelength. Every laser has specific eyewear. CO2 is the only wavelength where if you have loops with side shields, you need nothing else. Or if you have an erbium laser, you need to get erbium clip-ons that clip onto the inside of loops. If you use a diode, you need the diode clip-ons that clip onto the inside of loops. But CO2 is the only one with the loops with side shields and they're fine.
And how about
You gonna say something?
The lens protects. You don't need the glass. But for the roof, you need to have just a regular glass. Like regular.
Yeah, regular glasses, as long as they're side shields, as long as they're side shields.
Or just let it go.
So ditto for the patient and the assistant, right? Like the
Yes,
kind of glasses
yes,
you're wearing now.
when you get, yeah, these I won't
CO2
use.
specifically.
Yeah, these I won't use when I'm working on patients that don't have side shields. If they had side shields, I could use them. Yeah. You got 3 pair of glasses with every laser. One for the dentist, one for the assistant, one for the patient. And the glasses must be wavelength specific, and the glasses must say on them what they protect against. Shoot.
Similarly related to safety lasers, is there any way to increase the beam diameter?
Oh, absolutely. Absolutely, absolutely, absolutely. How do we know how far the Earth is from the moon?
Speed of light and mirrors. Something like that.
Exactly. The Apollo astronauts put mirrors on the moon. We know exactly where they are. So from the Johnson Space Center, they shoot a laser, hits the mirror. It's reflected from the mirror back to the Johnson Space Center. They know the speed of light. They know how long it takes to get from here to the moon and from the moon back to here. So they know exactly how far the Earth is from the moon. When the beam leaves the Space Center, it's this wide. When it hits the mirror, it's this wide. Because laser energy, when it comes out, is collimated, coherent, and monochromatic. Collimation gets lost over time. So when I'm working on some tissue, and I'm cutting, and I hit the jugular vein, which I do from time to time, I just back up. Because when I back up, the beam gets larger. Small beam cut. Move away, the power density decreases, the amount of power per square millimeter decreases. So as the beam diameter gets bigger and bigger and bigger and bigger and bigger, the amount of cutting efficiency decreases drastically, and the amount of coagulation increases drastically. So cut, coagulate, small beam, big beam, small beam, big beam. Got it?
Yeah, if you don't mind, a similar unrelated question. For the gingivectomy that you demonstrated?
Yeah.
Is that a gingivectomy where you're when you do it with a laser, do you excise the tissue, or do you, speaking of ablation, do you just ablate it down to the profile that you want?
If you had a blade, how would you do it?
I would. Yeah. Is that an external bevel gingivectomy? Is that the same thing?
If you have a laser, how are you going to do it? The fact that you're using a different tool doesn't mean you throw out all the knowledge and all this stuff that you've done in the past. You're using a different tool to accomplish the same thing. So if you would do it with a blade with a inverse bevel, you're going to do it with a laser with an inverse bevel. While you're here, I'm going to give you something to read for a second. This is your homework assignment. Okay. Just take a fast look at the chapter on implantology and minor and major maxillofacial surgery. I don't know if you know who Rob Strauss is. Have you heard of Rob Strauss? He's MD, DDS. He's been the director of the oral maxillofacial surgery program at VCU for 100 years. And he wrote one of the chapters. Just take a look. There's 2 oral surgery chapters. There's 1 implantology chapter. Cosmetics, aesthetics, and then it's almost 9:30, so I'm going to go or my wife will hit me. I could show you bruises. Okay, so you know the gingival margin should follow the lip line. So not so good. We have altered passive eruption. We have the lateral incisor locked out lingually and super erupted, and the gingival margin is very, very irregular. So if I'm going to do a little bit of a gingivoplasty and cut down the incisal edge, it looks a little bit better than if I put 2 laminates on. Looks a lot better. 1, 2. So I don't do a bazillion laminates, but virtually every laminate case I do, use the laser. Let me see what else I can bore you with. Fixed prosthetics. You can't find a retraction cord in my office. Actually, that's not true. Last time I used a retraction cord was on my mother-in-law. I made sure I packed that cord really tight. Otherwise, I use my laser for gingival retraction. I don't use cord. Get a beautiful impression, whether you're using a digital impression or just plain old impression material, get a wonderful impression. Aptus ulcers, a large aptus lesion. We can treat that with any number of lasers. Disappears just about instantly. The pain is gone instantly. A couple of aptus ulcers here. Melanin pigmentation I spoke about briefly. And do I have anything else? Well, yes. Yeah, that's like an hour lecture on its own, periodontal pocketing. But email me and I'll give you some information about it. Oh, come on, that's funny. Free laser, if you know the answer to this question. Free laser. Where's Albert Einstein buried?
Princeton, New Jersey.
Say it louder.
Princeton, New Jersey.
Princeton, New Jersey. He was a professor of theoretical physics in Princeton. And when he passed away, who's a free laser? You think I'm dumb? Yeah, he was a professor of theoretical physics at Princeton, and he's buried in Princeton, New Jersey. I gave a 2-day course in Princeton years and years ago, and I forgot that he was buried there. And in my 2-day course, I do a lot of Einstein and physics and all that stuff. And somebody raised their hand and said, "Hey, Dr. Bob, take a look out the window, a couple of thousand feet." That really freaked me out because I thought maybe he was listening to me. So I showed this picture to my wife, and she said, "I know one of you is a wax dummy. I'm not sure which." That was her fault. I don't know why she said that. But I keep on running into it. Wherever I am, I always keep on running into it. A couple of years ago, I was transiting back from Bahrain to the U.S., and I transited through the Frankfurt airport, and he was just sitting on a park bench in the Frankfurt airport. So doesn't say much, but nice guy. That's me. I'm going to give you my email address and my phone number, especially for the residents who ever have any questions, any concerns, anything at all about lasers. My passion is teaching. I'm a full-time wet-fingered dentist in general practice in Manhattan, but teaching is my passion. So my email is so stupid you'll never forget it. I use a laser. My name is Bob, and I'm a DBS. So laserbobdbs@gmail. Full Spectrum Seminars is a website I put up. Take a picture of that. I give courses in River Edge, New Jersey, 2-day courses, 3-4 times a year on tongue ties, on snoring, on sleep apnea, on lasers from A to Z. And we do have discounted rates for residents. So if anybody needs any information, please contact me, email me. If I don't get back to you immediately, it means I'm on a plane going to Timbuktu or somewhere. 2 weekends a month I'm traveling. But I will get back to you as soon as I have the ability to answer your email. Okay,
Good job. Great job, Doctor.
Thank you.
All right, so don't go anywhere. We have to get a selfie. Come here.
Oh, absolutely.
Turn around, we're gonna get a selfie with everybody.
Oh, boy.
That's that, and then John will get some pictures outside. Everybody in? Another one. Okay, we got it.
Lovely, lovely.
We got it.
Okie dokie. Anybody have any questions? Anybody want to ask about any specific
What's the
procedure?
percentage of infants that are tongue-tied?
Okay, so the only 2 countries that screen for tongue ties at birth are Brazil and Israel. The incidence of tongue ties in Brazil is 11%. The incidence of tongue ties in Israel is 11%. So what's the incidence of tongue ties in the United States? I don't know. Got to be 11%, give or take. Anybody else? Any questions? Yes, sir.
I remember in my residency training, we spoke about tongue ties in infants as being diagnosed by not being able to move the tongue tip past the alveolus, or along those lines.
That's one of the things, yeah.
But if you find, let's say you have a case, a neonate comes to you,
Right.
where objectively it appears that, they don't have a tie.
Okay.
Where visually and on your exam, you wouldn't diagnose it with a tie.
Okay.
But, the kid has difficulty feeding.
Right.
And, one of your colleagues believes it's related to a tongue tie procedure. You feel comfortable doing that? I don't know if this is really ethics category or diagnosis category.
Okay. It's a diagnosis category because it's more than just looking at the tongue. It's about 17 dozen different things. There's a whole sheet. And I give a 2-day course on this, and we spend a good 2 hours talking about diagnosis. my course is so unique that it's been given registered copyright status in a whole bunch of countries. It's the only course given by a dentist anywhere in the world that's allowed to give CE to IBCLCs, International Board of Certified Lactation Consultants, because the IBCLC people have vetted the content. The diagnosis is a good 2 hours, 2.5 hours of the thing. The course is called the PEEL technique, PEEL. It's an acronym, just like laser is an acronym, PEEL is an acronym. Peristalsis, elevation, extension, lateralization. Those are the 4 movements the tongue must make. You must have peristalsis, must have elevation towards the roof of the mouth, must have extension, you must have lateralization. You could have 2 of the 4, but not all 4. If you don't have all 4, the odds are that there's a tie. The problem is that 80% of all ties are posterior tongue ties. I hate the word posterior. They are ventral tongue ties. They're on the floor of the mouth. So you have to actually lift up the tongue and take a look. There's a whole chapter in there about tongue ties that somebody Convissar wrote. But posterior tongue ties always go undiagnosed